Boker Tov, good morning. Back in 2015, I was supposed to come here to learn how you guys do trauma. And last minute, Dr. Herzenberg called me and offered me a fellowship. So if Dr. Yaniv Karen is here, I'd love to formally apologize to him for ditching him. So now we're going to expand a little bit on the concepts that Marie just taught us. And the goal of today is really just to teach you a method, a very systematic method, so that if you apply this method for every patient, you don't make mistakes. And the biggest senseis in the industry, Dr. Herzenberg, Dr. Edelman, they apply these steps every single case. So we've learned how to identify that there is a problem. And the ABC teaches us how to identify where the problem is located. And we call that problem the apex of deformity. And to find that apex, we have to realign a desired proximal mechanical axis, or anatomic, to a distal axis. And here we're going to focus on the tibia for about 10 minutes. The proximal segment has that mechanical axis, and the distal segment has a mechanical axis, and they each have 3 or 2 very similar strategies to identify them. For the proximal axis, we can either use the normal proximal femoral axis. We can use a mid-diaphyseal line if and only if it creates a normal MPTA. Or we can choose our own adventure and create our own MPTA. I like to use these strategies from left to right wherever I can. So how do I decide which one I use? It's simple. I'll use a proximal mechanical axis if it creates a normal joint line congruence angle, and obviously if there's a normal LDFA and MPFA. I will use a mid-diaphyseal line if for any reason I cannot obtain standing x-rays. I don't see what the femur looks like, and if that mid-diaphyseal line creates a normal MPTA. That's, I think, the easiest solution if the apex is in the diaphysis. And finally, if both of these previous options are not true, if the mid-diaphyseal line does not create a normal MPTA, then I have to make my own normal MPTA. That can be based on the contralateral side, or it can be based on population normals in patients who do not have a normal side. Now, very simply, to find the distal tibial axis, it's the same thing. However, we cut the first option, so we can either use a mid-diaphyseal line or we can use a normal LDTA. And the restrictions are the same, right? We can only use a mid-diaphyseal line if it creates a normal LDTA, so you have to always double check. And finally, if you don't have a normal mid-diaphyseal line that creates a normal LDTA, you choose your own adventure. So let's go straight into cases and see how we apply that method. So this is an adult with a leg length discrepancy and an obvious varus leg, but let's not trust our eyes. So before we run the ABC, we have to go back to the basics. And the basics means that we always have to measure the mechanical axis deviation. And I use it mostly less as a quantitative test, but more as a qualitative test. So I draw the mid-diaphyseal line, I make a mental note that it's in varus because it's medial, but I don't really measure that amount. I'll measure that amount if I'm doing growth modulation and I want to see if from visit to visit there's a correction, but otherwise not so much. So now we know that the right leg is in varus, the left leg is normal. Now we need to identify which bone is the culprit. And to do that, we draw the joint angles. I'll give it to you. The culprit here is the tibia with an MPTA of 70 degrees. So Galina, you're off the hook because we've never met before. So we decide to correct the tibia. So let's jump in the thick of it. Let's plan our procedure. Let's plan the correction. Let's figure out what we're going to tell our patient. And to do that, we have to measure the ABC. When proceeding, always erase all the lines you've already drawn. So if you're on a PAC system, erase everything and start with fresh lines. One of the most common mistakes is we try to draw the ABC with the previously drawn lines. It's a mistake. So now what we're going to do is use the previous strategies that we've learned to try to figure out where the apex is. So the goal is to realign a proximal axis to a distal axis. Let's find the proximal axis. In this case, I have a normal femur above because I know that the LDFA is 87. So all I'm going to do is take that line and extend it distally. And it's as simple as this. What I want is to realign the distal mechanical axis to this line. And I know it's going to be worthwhile because this line will create an MPT of 87 degrees. So distally, I have a long segment. I can use the strategy on the left by using a mid-diaphyseal line if it creates a normal LDTA. And by drawing the mid-diaphyseal line and double checking, we have an LDTA of 88, which is normal. And that's it. We've drawn our two axes. We found the place where these two lines intersect, and that's called the apex of deformity. And that apex of deformity is very proximal, as we could see, for example, in a case of growth arrest, partial growth arrest of the proximal growth plate or Blount. And now we can measure the magnitude of deformity by measuring the acute angle, in this case 20 degrees. So that tells me that I need to correct 20 degrees of proximal deformity in the tibia. That's the science, right? There's not a lot of different answers that we can come up with. However, B and C becomes the art. B and C is dealer's choice, surgeon's choice, and you can use whichever method you're comfortable with whichever tool you know how to use. So the correction, the bone cut and the correction in my hands might be different than the correction in Dr. Gedalovich's hands. However, we always want to apply the rules, to obey the rules, really. So we'll do the bone cut as close as possible to that apex, wherever it's surgically and anatomically feasible. In this case, it's right below the tibial tubercle, so we can decide to cut the bone right there. Then you can decide if you want to do an acute correction and plating, an acute correction and nailing, a gradual correction with external fixation, and that depends really on which methods you have access to in your reality, in your practice. However, in each eventuality, in each scenario, you want to realign the axes. So if you've cut the bone at the correction line is found by actually measuring the obtuse angle, so the wider angle, and drawing a bisector of that angle. And that bisector will come in very handy if you're going to use a classic Ilizarov correction method, and you'll have to position the hinge along that line. But this is 2025, right? So nobody uses classic Ilizarov anymore, or almost no one. So if you use a hexapod, you know that the software will apply the hinge, the vertical hinge, on that line. If you do an acute correction, then you have to either put the hinge on that line as well, or you have to take into account that if you cut the bone away from that line, you have to input obligatory translation. So in this case, we cut on it, we hinge on it, we do an open wedge, and this is what it looks like at the end of correction. It creates a normal MPT of 87 degrees. This is anatomically feasible, and this is it. We have a minute and a half to run the next case, a real life case. So this is a 2.5-year-old girl with Blount disease. And very quickly, we measure the mechanical axis deviation. It's in varus, it's medial. So we go straight into the joint angles. Joint angles here are done intraoperatively with an arthrogram. It's much easier, but you could also derive it on the pre-op x-rays. And we find that there is a normal LDFA, an MPT of 71 degrees, and we decide to pick the tibia for the correction. Pretty standard so far. Now, the tibia is the culprit, but where is the deformity? That's where we apply the ABC. And to find the ABC, we realign the proximal mechanical axis by extending the tibial, the femoral line. Once again, it's my favorite method if I can use it, right? So here I'll do it. And distally, I'll use the long diaphyseal segment if it creates a normal LDTA of 88 degrees. I'll find an apex at the proximal tibia, and it's a valid strategy. So we could decide to do an osteotomy at the level of the deformity, or here in this case, Dr. Herzenberg did something that's slightly novel. He found an 18-degree correction, but he decided to do the correction at the physis to use this patient's natural growth to make it minimally invasive. So we decide to hinge slightly away from the joint. So what is going to happen if we do that? Well, it does create some obligatory translation in this case, right? So we have to check the alignment. We end up with an MPT of 89 degrees. So although it's not exactly by the book, right? We're not exactly applying the method. I showed this example to show that sometimes, for the sake of safety, less invasive surgery, we can transgress the rules if it makes sense to do so. And this is 9 months after the surgery. Despite the fact that the physis medially is diseased, it still has the potential to correct, and we want to achieve that correction before that physeal bar sets in, so before the age of 4 ideally. And we end up with a neutral mechanical axis. Thank you very much.